A warm welcome to everyone. Today, my topic is the theory of bundle bone and its implication in implant aesthetics. So, in this topic, we are going to see what is bundle bone, what are the advantages of bundle bone, and how various authors with several experiments they came up with the solution of preservation of bundle bone in anterior implant aesthetic cases. So, what is a bundle bone? It is a part of the alveolar bone where periodontal ligament fibers are inserted as a bundle, especially the Sharpie's fibers, which are the principal fibers of the periodontal ligament, are embedded to the cementum through the bundle bone. It is in the form of a cribriform plate through which the blood supply to the periodontal fibers are done. So, coming on to the traditional brain mark protocol. What is the brain mark original protocol? The tooth extraction with 6 months of wait period followed by the implant placement and then another 4 to 6 months of waiting period and then stage 2 surgery. It was given by Brandmark before 50 years where implant dentistry is of hard tissue oriented. Now implant dentistry is paradigm shifted towards the soft tissue aesthetics or the pink aesthetics. So this is where Brandmark's protocol gets ahead in the immediate implant placement cases. So this is how healing of the extraction socket happens. It takes 6 weeks to 4 months for the extraction socket to completely reorganize. So several authors did several studies regarding the tissue changes or alterations after tooth extraction. In Carlson in 1967, he stated that 25% decrease in width of the alveolar bone in the first year. And then Tatum and Mish also observed 40 to 60% decrease in the alveolar bone width after the first 2 to 3 years of extraction. And then one particular article from Araujo in 2015, he stated that after an extraction, there is volume loss on the buccal side around 10 to 11 to 22% vertically, and then 29 to 63% horizontally. So there is a loss of width of the bone crest, mainly in the buccal side, up to 50%, he stated. And then Araujo and Linder in 2005, they also stated that the loss of the periodontal ligament, which happens after an extraction, it interrupts the blood supply to the bundle bone, which leads to its resorption. So these events have a direct impact mainly on the thin buccal bone wall. So several authors, they did experiments to preserve the bundle bone. Botticelli in the year 2004, he stated that placement of immediate implant could be an alternative. But this hypothesis was denied by different researchers as it was understood that implant does not provide a blood supply to the bone. It was proved that the volume loss around the immediate implant is quite similar to the after effects of the tooth extraction. So another experiment was wider implants with the flap elevation and then narrow implants without a flap. And this was also does not have any positive effect on the bundle bone preservation. And then Jung in 2018 and Melanie in 2015, they devised an experiment and they suggested rich preservation to counter the bundle bone resorption. But it reduced the loss of the volume after extraction, but it does not preserve the bundle bone. Another experiment was the connective tissue grafts in the immediate implant placement to counteract the bone remodeling, but it was also in vain. And then in 2007 and 2010, in 2010, root submersion technique was introduced, and in 2010, Herzler in particular, he introduced the socket shield technique. What is a socket shield technique? A partial root fragment was retained around an immediately placed implant with the aim of avoiding the tissue alteration around the tooth extraction. So what are the principles? The root is retained in such a way that the buccal plate will be intact. The root portion, the root section, periodontal attachment apparatus remains vital and undamaged, which prevents the post-extraction socket remodeling around the extraction socket. Now, where are the indications? It can be done on endodontically involved tooth, around a root fractured tooth, a tooth with a periodontal pathology, a perforated root pathology, and then in an unfavorable crown root ratio and in a deciduous tooth also. Worthington in the year 2004, he stated that around a 4 to 5 mm of bone width and 10 mm of bone length is ideal for the placement. So what are the contraindications? Presence of pus, lack of bone beyond the apex, close proximity to the anatomical structures, and then so this is what is the steps in root socket shielding. Okay. First, the tooth is sectioned in a horizontal manner with 1 mm clearance from the gingival margin. So the first is a horizontal sectioning of the tooth, and then with the help of a long shank carbide bar, the vertical sectioning is being done, and then the root apex of the root is also removed. And then, as you can see in the picture D, a contouring on the buccal side is also done to enable the closure of the flap. A football-shaped diamond is used for contouring the buccal side. And then the immediate implant placement is done, as you can see in the picture E. And then a jumping distance of 2 mm is maintained. So this is how it looks. A 1.5 mm of shield thickness with a jumping distance of 2 mm, and then ideally 3-dimensional position of the implant. So in 2011 and 2004, Martin and Kahn, they recommended a 2 mm of jumping distance between the shield and the implant placement. So what the implant has to be placed in an ideal 3-dimensional position for the aesthetic result. So what is a 3-dimensional position? 3 mm apically, and then 1.5 mm away from the tissues, and then 2 mm from the buccal danger zone. This is what is the 3-dimensional placement of the immediate implants. So the take-home message is preserve the bundle bone when possible. Ideal implant positioning is mandatory for the long-term success of the anterior implants. Always use a stent while starting the initial drill. A jumping distance of 2 mm is ideal, and always keep in mind the 3D placement of the anterior implants. With this, I conclude the comprehensive knowledge in the implant biology in the immediate conditions. We can build a solid criteria for making the critical decisions in our daily practice and apply them in the different clinical situations. Thank you.